not only share this video with others, it will be an open YouTube channel you can share with others, but also to remind ourselves, in fact, to leave a historical trail, because this is indeed a historical moment as we're going to establishing one of the most important Pan-African health agencies. Today, we have with us, we have with us Chimwemwe Chamdimba, who is the program head on the African Medicines Regulation Harmonizations. We are very lucky to have her here, because I think to have a person of such high level within that program, and also someone who has really worked hard at bringing this out and knows the inside out, is important for us. As you know, the African Medicines Agency Treaty Alliance, which is AMATA, was formed way back as a concept in almost 2017, when the treaty was first adopted by the African Union and it was being negotiated on. The idea was that the African Medicines Agency Treaty Alliance would be formed from patients, health professionals, policymakers across Africa who have a great interest in furthering or making sure that this treaty is ratified, put into place, and the agency comes of age and is operationalized so that we can all enjoy good health, and especially One Health. And with the pandemic in the intervening section, we began to realize how important it was to have such an agency in place. You saw the mess that was left in the confusion of vaccines. African countries were starting and stopping their vaccination programs. There was misinformation, infodemics, and we were basically in disharmony over that issue. And that was the last place to be in disharmony, I think. So now, today, I'll pass the baton over to Chimwemwe Chamdimba from the African Medicines Regulation Harmonization Program to let us to start where we are, the history, and then we can take forward with questions and answers. Chimwemwe, over to you.
Thank you very much for having me in this session. I think to us it is a very important session where we are able to really engage and discuss with the wider audience when it comes to patient groups and other stakeholders that are critical when it comes to regulatory harmonization on the continent, as well as the operationalization of AMAM. I want to start, before I go into where are we, I want us to look back to say, where are we coming from, and how did we get where we are, and why did we get here? And then how are we looking forward in terms of the future of the African continent on issues around regulatory harmonization and regulatory system strengthening. So I want to take us back in 2009, when the regulators across the continent met, and I think everyone realizing and recognizing the disharmony that was there. 55 member states, each one having their own rules of the game when it comes to regulation of medical products, and each one of them not even recognizing the decisions that is made by the neighbor. But we know that we really can leverage on each other and be able to work with each other to leverage on our capacities as our regulators in making regulatory decisions. We don't, all of us don't need to have all the capacity that is needed in the world, but if we come together as regulators across the continent, we can go a long way. Mainly it was to ensure that we have access to quality assured, safe and efficacious medical products to the people of the African continent, which then was not the case. And it's still not the case. We still have a problem when it comes to access to safe, efficacious and quality medical products to the African population. And I think it is evident with what happened during COVID. You talked about it earlier, I think. And we also, if you look at what is recently mushrooming all over the continent in terms of prevalence of substandard and falsified medical products across the continent, the Gambia case and the recent Cameroon case, it just shows you that we have a long way to go. And we recognize this as early as 2009. And when the regulators met at that point, we really reflected on what can we do better what systems and structures do we already have in place that we can leverage on and ensure that we work in harmony as regulators across the continent. And I think this is what then led us to the establishment of the African Medicine Harmonization, a program that was led jointly by the African Union structures, the AUD and APAT, which is ourselves, and the African Union Commission, jointly with other partners, including WHO and other partners that supported us, working with regional economic communities and regulators. The idea was, can we work together, harmonize standards, so that when manufacturers are getting into the market, they don't have to navigate 55. But now, if we work through the regional economic communities, we reduce that 55 into 6 regional economic, we started with the 6, but ultimately there are 8 regional economic communities across the continent. If we are able to harmonize and we are able to work within the regional economic communities, we've already started doing something. So we started with learning from one regulatory function because we knew that, well, there's a lot. There are so many regulatory functions that we have to navigate. However, I think what was key, and for our learning, we started from harmonization of registration of generics so that we learn lessons. Once we learn, then we are able to expand to other regulated products and other regulatory functions, which is a process that we have gone through since then in the regional economic communities. We have been working on harmonized standards and regulations in 5 regional economic communities: East African communities, SADC, West Africa, IGAD, as well as Central Africa. We have started harmonization initiatives. But I think over the years, work sharing has happened. We have tested the systems when it comes to harmonization in the regional economic communities. And yeah, they are working, but we realize that there's also need for cross leveraging and cross harmonization across the ranks so that we look at Africa as a whole and move from now the regional economic communities to one continent, especially when it comes to sharing of capacities across the regions, being able to do work sharing, reliance in terms of regulatory decisions that are made across the regions. So you can see we have been moving with regulatory harmonization over the years. And then we noted that, yes, it's a program, we've been running it, and it's showing to be, after testing it, I think in terms of reducing the time it takes, quite a significant reduction for the time it takes when an application is made to the time it is introduced into the market, meaning that we have also reduced the time that a patient can access the medical product that is needed to respond to a need. So basically, I think we then realized that we need to sustain these efforts. We need to build on these efforts and ensure that there's continental harmonization, there's continental reliance. So yes, the treaty was adopted. I will not talk about it because I think you already introduced it when you were giving introductory remarks. When the treaty was adopted, it was an exciting time for us because then we knew that the work that we have been doing since 2009 on harmonization really is going to find a home. But the adoption of the AMA Treaty and the coming into operation of the AMA, it doesn't necessarily mean that we replace what has been going on in the regs and we replace what the regulators are going to be doing. It is an ecosystem that is of 3 levels, an ecosystem that is composed of the national level, where the national regulator still is an important entity because it is the national regulator that is going to take up AMA decisions and implement them at the national level. Then there are the regional economic communities that bring together subsets of member states and be able to do capacity building, support them when it comes to implementation of those decisions that are made at the African Medicines Agency level. Moreover, African Medicines Agency is going to depend on experts across the continent. And I don't think AMA will be able to deal with 55 countries alone. AMA will need to depend on the capacities that are available in the countries and in the regional economic communities. So we look at the 3 levels really being able to be interlinked and interrelated and sharing information and be able to work together. In addition, I then want to say that at the AMA level, we don't expect AMA to deal with all medical products. We are expecting that AMA is going, as per the AMA Treaty, it's going to support where there there's limited capacity. When it comes to complex molecules, when it comes to traditional medicine and other priority products responding to emergencies, AMA is going to be critical when it comes to that. But still, there is a subset of products that is going to be dealt with in the regional economic communities. And there are products that basically are supposed to be handled at the country level, and there would be no need for them to be handled at the regional as well as the continental level. I hope the colleagues, everyone in the webinar has had an opportunity to look at the call that we sent out recently on defining a criteria for products that are going to be handled at the continental level, differentiating the products that are going to be handled at different levels. It just closed in terms of feedback, but we sent out a public call for comments for the public to comment on the criteria. But it's a living document, which I think time and time again, we are going to give an opportunity to the public to provide input when it comes to decisions. Now, where are we when it comes to AMA? There are two aspects on AMA operationalization. There's the administrative aspect, and then there's the technical aspect. On the administrative aspect, we are looking at really setting up systems and structures of the African Medicines Agency, the human resources, the administrative, finance, procurement, and all the systems that are required for an organization to run. And then there are technical aspects which deal with the technical work that AMA is going to undertake. And I think if we are aware, or we may be aware, that the Executive Council of the African Union made a decision that the African Medicines Regulatory Harmonization is the foundation for the establishment of the African Medicines Agency. So what does that mean? What that basically means is that we have done a lot of technical work, which AMA will have a, somewhere where it will start from. And it will not start from zero. And we have always said that on the technical aspect, it's not a start-stop. It is a continuous process where AMA is picking up what the African Medicines Regulatory Harmonization has been doing over the years and ensuring that it is now done in an organization that is more sustainable and systematic for the continent. Secondly, on the admin part, our colleagues at the African Union Commission are mandated as per the treaty that forms the African Medicines Agency to drive the setup of the administrative aspects on the operationalization of AMA. So currently, we have a task team, an AU task team on AMA, which really is formed by the different entities of the African Union, including the African Union Commission, the different departments of the African Union Commission that are key for setting up the administrative structures of AMA. And we have the AUDNAPAD as part of that, which is providing now the technical leadership when it comes to the technical aspects on the operationalization of AMA. And then lastly, we have our colleagues at the Africa CDC, because we really want AMA to be responsive to the needs of the continent. And we can always get the data, we can only get the data from the Africa CDC that African Medicines Agency should be responsive to, and the African Medicines Regulatory Harmonization should be also responsive to. Now, on setting up administrative structures, I think we have really moved. We have the Conference of State Parties that has been established, and it has been meeting since the last 2 years to provide leadership in setting up the structures of the African Medicines Agency. So the Conference of State Parties is composed of ministers of health from countries that are parties to the treaty. They come together to make policy decisions, policy recommendations, and strategic recommendations on AMA when it comes to the next steps. So they have also selected the Bureau. The Bureau is a subset that really drives the work, the strategic work of AMA in between the Conference of State Parties meetings. So this has already been set up. Ghana, the Minister of Health of Ghana is the chair of the Bureau of the AMA State Parties. We are currently in the process of setting up the third layer of the governance structures, which is the board. We have quite advanced. We have received nominations from the different regions. We are remaining with a few for us to be able to conclude the setup of the board. And we are very hopeful and very optimistic that in the next 2 months or so, we will have the board functional, and it will be meeting. And it is the board that is going to take up the responsibility of recruiting the AMA Director General. We have finalized the terms of reference, but currently we're just waiting for the board to be set up so that they can provide oversight on the recruitment of the AMA Director General, who is then going to be responsible for recruiting the rest of the staff and dealing with the structural issues and administrative issues of AMA. And on our side as a UDNEPA, we are also moving on the technical side, technical aspects. We are using the work that has been going on the continent over the years. We have really strengthened the continental technical committees, which are going to drive the technical and scientific work of AMA. We have 9 technical committees that are currently operational. We are in the process of setting up the 10th one on pharmacovigilance, but the rest are really functional and they are moving in terms of driving the technical aspects. We are developing the different standards and guidance documents as well as processes on technical issues that AMA is easily going to be able to take up and run with them on specific issues. We understand that we need to strengthen the regs and we need to strengthen the NRIs to be able to anchor the African Medicines Agency. So we are also in a drive. We have done assessments in terms of capacities, and we have mobilized stakeholders and partners to support strengthening of the regs and the national regulatory authorities. We are working on a reliance framework on the continent that we want to really countries and regs to use to facilitate reliance on regulatory decisions. Because if AMA decisions are to be implemented, there will be need for reliance mechanisms to be in place. So we are already supporting, we are piloting it in the East African community, where IGAD and ESC are currently implementing an indirect reliance project. We want to see how it comes out, and we'll then roll it out across the continent to facilitate reliance on AMA decisions, but also reliance on decisions made by regulators outside the continent that are stringent. So we are moving, we are making progress, and I think if everyone asks, we always say AMA is a moving train. It started in 2009, and we are just concretizing it now. And I think one last thing that I know we'll have a conversation and we will talk about so many other things, but one last thing that I wanted to also emphasize on is that countries are moving when it comes to ratification. Of course, it was disappointing in the last 6-8 months, 1 year, that we had stopped kind of at 23. And we were like, what is going on? What are countries doing? We have to, really push with our advocacy efforts. So we are doing advocacy and we're ensuring that we really talk to the member states that have ratified and those that have signed and not ratified, and those that have not even signed, so that they can, make movements, change the number of countries. But as we speak today, the number has moved from 23 to 26. It is exciting that we have now Kenya that has joined the state parties. We now have Congo that has also joined the state parties, and Cape Verde that has also joined the state parties, making the number 26. And it's an exciting time for the continent. And we will continue strengthening our advocacy efforts so that we have more and more ratifications being done, and so that we achieve the 55 being parties to the treaty. So let me pause there. I know there are a lot of things that we can discuss, and I can't cover them in one go. But as we do the conversation, we will be able to tackle most of the issues. Thank you.
Thank you very much, Chimwemwe. I think you've really done a great job introducing it with passion and that. I think you're absolutely right that the agency will be the fruit of all that's going on. It's a long process of harmonization, and NEPAD, we must thank NEPAD for having pursued this relentlessly and making sure people sat together and talk. The question I'm going to pose you now, it was very important to us in 2017. In 2017, within the treaty, there was a provision. This is a draft treaty version 8. If those of you who are joining us, please look at something called the Entebbe statement. This is our Entebbe call to action we made. Within it, there was a draft article within AMA, I think it was Article 19, which actually showed us what the composition of these technical committees will be. And therein, patients were actually mentioned by name. But subsequent to that, after redrafting it, the current state is actually current treaty. The article has moved to Article 22 on composition of technical committees. But what that one says is quite different to what that actually said. I would like to now check on this. Yes, Article 22 does say that they will involve other experts and relevance into this discussion with AMA. The question we want to ask is, how can we ensure that this AMA framework has meaningful engagement with patients and academia of Africa, knowing full well that, as WHO has said, that lived experience is expertise in their own right, meaning patients who have lived with a condition or disease who need these medicines are experts in their own right. How should we look at this? How can we go forward? And I have their suggestions there. I know we can't foresee anything. Could you predict where we patients and academia could engage with this and be part of that, as, for instance, in the European Medicines Agency?
No, thanks so much. Actually, you are spot on. You are totally right. Patient groups have a role to play in shaping the regulatory landscape on the continent. And as you're saying, there are some that have lived with the condition for quite some time, and they're experts in their own right, and they can effectively contribute to setting the systems of the African Medicines Agency. And I think in addition, also, whatever decisions that are made by the African Medicines Agency, as well as the regulatory harmonization process, because even in the regs and at the NRA level, it directly impacts them, right? So what we noted that, we know exactly what you have noted, that have we really engaged strongly the other stakeholders, including the patient groups, as well as academia and the industry. In the AMRH initiative, we have at least tried as much as possible to engage the academia through the regional centers of regulatory excellence. You may be aware that we have set up these regional centers of regulatory excellence to drive research and capacity strengthening, as well as contributing to the setup of standards, guidelines, and all scientific work. So in this regard, we really made a deliberate effort that all the work that is done in that front, academia are involved. It's no longer just the regulator, but the academic and scientific community is also involved. Recently, there was a decision that was made. We have a partnership platform under the AMRH, which has been running for quite some time. And under the partnership platform, we have technical partners, of course, as well as funding partners that are supporting regulatory harmonization and the African Medicines Agency. And I think with so much understanding that we still have a group that we have not effectively engaged, which are the patient groups, which are the industry itself, as well as the policy advocates. We have tried, but I don't think we've really done a thorough job. We can say we have not done 100%. So the last meeting of the steering committee, when the steering committee met, there was a decision that was made that we should form, in addition to the technical partners group and the funding partners group that we have on the partnership platform, we need to form 2 additional groups. And this is the industry group, which of course is going to be an observer, but we want to really be exchanging information with the industry, being able to do knowledge sharing with the industry, but also being able to consult when we are setting standards and guidelines. There's a lot we can get from the industry. We already started when we were developing the guidance documents on GMP, as well as now the recent documents that have come out of the evaluation of medical products. We've made sure that we engaged with the industry in that regard, but we want to make it more systematic and more formal. So we are setting up, we are now currently in the process of developing TORs, for this group, and we should define how we are going to be able to effectively and more efficiently engage the industry as the work is ongoing from the operationalization point to the time that we will become more systematic. Similarly, the patient group, a decision was also made by the steering group that patient groups as well as NGOs, we also ensure that we form a targeted group. And these ones, we want them to be effectively involved in the work of the AMRH, as well as the African Medicines Agency, as when it comes fully operational. So we still have a place, and we are working on terms of reference. And I think this is the right time to indicate that it would be a missed opportunity if through yourselves, AMATA, we don't even consult on the terms of reference as we are setting them up. So when we have the draft ready, we would like to open, I think that we would like to ensure that we reach out to you and consult with you so that we provide input and ensure that you are effectively represented. Lastly, I think the AMA Treaty, yes, has been adopted. The AMA Treaty is there and it's running, and you have already seen where we somehow lost. From the beginning, we had highlighted very well that patient groups are going to be involved, even in the technical committees. But somehow we lost that text as we went through the consultation. I think it's not a document that it may never be reviewed. It will have an opportunity with calls from the patient groups themselves. We should have an opportunity. This is not the only one, by the way. We have received other calls on other aspects to say, can we go back and relook at some text there and ensure that we include it? So let's operationalize AMA.
Yes.
Then we can start the discussion.
Yes.
Can we make it better? How do we make it better to involve everyone?
Yes, we're very generous on this. I think we do understand that, and I said that needs. But as I said, from other international instruments that we see there again, they always say launch the ship and then complete the build-up as you're sailing. You know, this is what we'll be doing with this document, that the ship sails, so we're building it up. And clearly, I think where the European Medicines Agency has done, it's developed a new framework. It's something, guidelines or something additional to that framework itself, treaty provisions. And that's sometimes very sufficient because it becomes an additional protocol and it doesn't. But you touched on that matter of, we got the 15 from, thanks to honoring Michel Sidibé for having done that amazing roundup. You know, he's a tour de force, as they say in Africa, in diplomatic circles, and he could charm off anybody, you know, to join up. So I was glad. One of the questions that we are posing, it's like almost an aspirational. You know, in Africa, whenever you go out to game drives, they always say, we'll show you the big five, yeah? And the big five depends on where you are. They'll nominate an animal, which is one of the big fives. And no tour is complete unless you've ticked up at least 3 of the big fives, you know, 4. 5, I think the leopard is always, the leopard and the rhino, depending where you are, has always been missed out. We have our big five, you know, like DRC's, South Africa, your own homeland, and then we're looking at across Nigeria and others. How important is it to have them in there symbolically? You know, big five, you know, they're impressive animals, you know, they're impressive countries and economic giants. How important is it to have them on board with the treaty?
All right, thank you so much. And actually, I'm going to desist from the big five until we have a big 55, because on the continent, we always say that our member states are equal. I will put that aside. I get your point.
Economic big five, if I could put it, yeah.
Economic big five. I will. Yes, let's look at the economic big five, or big three, whatever we can categorize it. But before I go to the economic, I want to go to the regulatory big five, because you've mentioned the number 5. We currently have the regulatory big 5. I'm saying the regulatory big 5 because there's a systematic process that has been used to identify the regulatory big 5. So I'm referring to countries that are ML3 countries, which is Nigeria, Egypt, Ghana, South Africa, and Tanzania. And I think everyone would be, it just because it has been objectively identified and objectively determined that these are countries that have capacity, you know, to the level of recognition that they are ML3. So automatically you would expect that these 5 should be part of AMA for us to really have a strong AMA. Currently, out of the 5 ML3 countries, we have 2 that are already parties to the treaty, which is Egypt and Ghana. But we are working with South Africa, we are working with Tanzania that have already signed, and they are working on the process of ratification. South Africa is still at parliamentary level. We are doing a lot of advocacy with South Africa. The NRA is keen, and they have taken steps to quite a far, you know, level that documents are already in parliament. But of course, they are remaining to be tabled. So we really need to hold hands and push and advocate. And as we said, we are trying to also see how we can work with Honorable Sidibe, Michelle Sidibe, to be able to push this agenda. Similarly, Tanzania also signed, but they're just, you know, about to make that decision in parliament. We are getting some good news that there's movement in Tanzania. Then we will start working with Nigeria. But as you're saying, we also, because we are looking at the pharmaceutical market, and we are looking at countries that have a lot of investment when it comes to pharmaceutical manufacturing. And South Africa becomes automatically one of them. And it would just make sense that we have South Africa as part of, you know, the African Medicines Agency. And let me assure you that when you talk to the Minister of Health, when you talk to the heads of regulatory agencies from these countries that we, as you're saying, in courts, the big 5, they are keen to be part of the African Medicines Agency. And I want to then relate this with the drive to local manufacturing. You know, there are countries that have also made commitments under the PAVM, the Partnership for African Vaccine Manufacturing, to, you know, to be front-runner countries when it comes to vaccine manufacturing. And we are keen to ensure that these countries that have made that commitment boldly to say we want to get into this, we should make sure that we work with them and they become parties to the AMA Treaty. However, I think where we are standing, it's not all lost. It's not been long. Actually, the AMA Treaty is the 2nd fastest treaty to come into force in the AU history. The first one was the African Continental Free Trade Area.
Yeah.
And the second one is the African Medicines Agency. It just tells you why. I think everybody now, when COVID came, everybody realized that we need this. We need access to quality products. We need access to safe products. We need to sustainably manufacture. We need to leverage our market for pharmaceuticals. And interestingly, on the Continental Free Trade Area, for the value chains that have been taken as priority, the pharmaceutical value chain is one of them. And so we want the 2 to really be able to work together to facilitate movement of quality, safe, and efficacious medical products across the continent, because the SCFTA has opened up, but we need to leverage on that market. We can only do that if we remove non-tariff barriers, which are technical in nature, that can hinder us from moving the products from one, you know, economy to the other across the continent. So we are keen, and I think I hope that by raising it up, you also had the same thoughts, and that we can work together and advocate.
Yes, we will have to bring
ensure that these countries are really parties to the AMA Treaty.
We do need that big 500. Now it comes to the second part. I think you brought it up very carefully, and then you hinted at it. We're just looking at participation of young people. I've been talking to Professor Amani. She's from the Pan-African University, which is set up by the AU. And we've been saying, how can we bring young Africa into this regulatory agency as a pathways? You know, can we create those pathways for them? And one of the things that we said was that we must stop thinking of ourselves as a generic market. Yeah? We should start looking at exporters of high-tech value-added products, and that therefore that would then bring in young people into it. What's your opinion? How should we bring this? I'm not talking of graduates from, say, Ghanaian universities or Tanzanian universities, South African universities, who are actually working for the European Medicines Agency at the moment, and FDA. FDA has about 20 or 30 identified, yeah? So we need to create pathways from African university, from biochemistry or others into this. What's your opinion on that? How can we facilitate that? And we have on our call at the moment also medical students associations in Africa as well. So it would be good to hear what your thoughts are.
Yeah, you're raising an important point. And I think, as you're saying, on our side as well, we fully recognize and understand the important role that young people play. If you maybe follow the African Union Development Agency programs and the AU programs, we have set up a program called the Energize Africa program. And under the Energize Africa, we have different pillars. And of course, our department is running the pillar 1. And under that, we have a critical skills bank initiative that we are running. And in that, interestingly, the first one to be considered is the pharmaceutical. And we have actually indicated that the pharmaceutical, we should zoom in into the regulatory aspects, to look beyond, of course, the traditional, as you're saying, and get into more innovative spaces, because we can't attract young people unless we get into the innovative spaces where it really challenges their ingenuity. So to us, we have set up that as a platform, because Energize Africa is focusing on youth. How do we involve the youth in development spaces? And as I'm saying, that with that being put in place, we'll be able to attract young people and bring in their innovations and bring in their participation into this space so that we drive this process together. But I think, as I said, through these platforms, this is also where we brainstorm on ideas. So this is where we also get your views on how you think we can best involve them. In addition to what we are doing, we are going to create a pool of them, a pool of young people with expertise, with critical skills that we can always reach out to and tap from as we operationalize AMA. Because I think you and me know that in the next 10, 20, 30 years, it is them that are going to be sitting here, and running it. And they need to be involved now, because if they are not involved, then we miss an opportunity to really grow a space where they can effectively contribute to the regulatory sciences space, as well as the broader pharmaceutical space, medical product space.
This reminds me of President Jomo Kenyatta's word that I'm planting an orchard of freedom trees, whose shade I will never enjoy, and whose fruits I'll never enjoy. It's for the next generation to enjoy. And
exactly.
So it's very good. Now on this same basis, now let's go to the issues of operationalizing. Everybody will say, yes, we are talking about quite higher up things, but let's talk about operations. We know Kigali is going to be the home of the agency. So that's central, and it's a very good idea after all that comparative analysis. And then we know there's a piece of land being allocated. I've been in touch with some of the African schools of architecture and others, and one of the suggestions that's come, I suppose I would like to put the balloon up. They would love to get involved in those design competitions that may come up for the design of these agencies, to show where we are. And at the same time, I spoke to African patient organizations, and they would also love to be part of that design consortium. As you know, many buildings like the European Medicines Agency buildings were designed in something called universal design, which means it's accessible by patients as well as experts, it's for everybody. What's your idea on that? Should we be opening up competitions for design, asking African, or are we going to go down some of the older routes? I call it the bad old African roots of 50s, where we point some brutalist architects from Europe or somewhere to give us buildings that don't fit us with our characters or natures or our aspirations. What's your thinking on that?
Yes, thank you for that. You are very futuristic, and I like that. But I'm sure that is going to come not now. It may come later. And I think it's an advice that when the DG is recruited, we need to put it on the table of the DG. To say, DG, sit here. Let's look at this. Let's be futuristic in nature and get innovative way of thinking around the design of the AMA building. But I want to indicate that currently it's not just land that has been allocated. It is land and a building. So we have a beautiful, I think you should visit Rwanda, and I'm sure Rwanda
we were there at the second public health conference. Yes, we will visit it now.
It's quite a big, beautiful building that I'm sure the first years of AMA, unless AMA expands, then they will need to expand, because the building has a lot of land behind it that AMA can, really innovate and think around it. But the government of Rwanda has been very generous. They have allocated a building, a huge building with furniture that the AMA DG just needs his briefcase or her briefcase to go and sit in the office and run once they are appointed. So that's what I wanted to highlight.
Okay, thank you. That is the most important news, because on that news, we would like to send us the address, and then we are trying to buy office space around the place, rent something, so that we'll be very close to that building from there. AMATA has always said that the moment we know where the building is, we will find a space. So thank you for that, but that's very good for us. Now, so we have got the building, we know it's all fully furnished. We have also known that the Bureau was working through with this, and then the Bureau is now looking at the conference of parties, state parties has been working functionally. We're now reaching out to the board, and then the board will appoint the director. Now, in this whole, I think the progress is really amazing, because I think it's becoming nearer and nearer, because knowing the fact that we have a turnkey building solution there. The next moves, I think the question that everybody will be asking, how are we going to work in that the new agilities we found during the pandemic, where it was government, whole of government, whole of society, whole of pharmaceutical industry, whole of private sector working together. Is there a way to continue this meaningful engagement, and how can we look at that as we go along? What's your ideas on that? That'd be very good.
Sure. Thank you so much. I think it's quite critical that we continue with the meaningful engagement. And I would like to say that the engagement, as I said earlier, will not start from zero. The engagement is building on prior engagement that we have had with different stakeholders under the Regulatory Harmonization Initiative. We within the AU made a decision that we actually going to be using the partnership platform that is existing to be able to coordinate different stakeholders that are going to be contributing to the operationalization of AMA. So the partnership platform, as I indicated, will be expanded. We are expanding it, and I don't think it's even going to be more than 3-4 months from now that we are going to have different groups formed that will together and collectively come together and really define the future of the regulatory ecosystem across the continent. And I want to emphasize here that every time we talk about AMA, let's talk about AMA in the context of the ecosystem, so that we don't forget that AMA is not going to exist in a vacuum and be the regulator that will solve all the problems and will leave behind the NRAs and the regs. So it is the ecosystem, and we will continue building on what we have been doing to ensure that all stakeholders are involved. In addition, I also wanted to highlight that you may be aware that every other year we convene a scientific conference on medical products regulation in Africa. This year, we are convening in November. And the conference, actually, it was meant to achieve this purpose, that can we bring together all stakeholders, academia, industry, patient groups, the regulators, the policymakers, and everybody that matters when it comes to regulatory issues. So we will ensure that this year we zoom in into AMA. We zoom in into the regulatory ecosystem. We are in November when we convene in Cairo, in Egypt. And I'm hoping that we will share information through yourselves so that you can share to the different stakeholders around the SCOMRA, the Conference of Regulatory Medicines Regulation in Africa. So as I'm saying, systems will be set up. We'll use existing platforms, but as AMA is coming up, AMA will be able to take up and absorb these platforms and make them more systematic moving forward in future.
Thank you. That's absolutely brilliant. I think the question that you started at the very start, you know, where you started saying how the harmonization of national regulatory authorities, they're working, were brought in. What the next question that we have here is for you is how we will continue building national regulatory authorities and also working with regional economic communities and reassuring them that they're a part and parcel of this greater Pan-African ecosystem. How's the idea on that? You've already hinted on it, but it would be nice to hear it again.
Yeah, no, sure. So when the treaty came into force, when we had the 15th ratification, what we did was that we developed a white paper on the emerging regulatory ecosystem in Africa. We'll be happy to share that with you. The white paper really just defines what is currently there, the capacities that are there, the gaps that are there, the linkages that will be there between the national, regional, and continental. And also, if we go back to the decision on the establishment of the African Medicines Agency, I indicated that it really has mentioned the foundation of the African Medicines Agency being regional entities, the regulatory harmonization through AMRH. So most definitely we are working together to shape AMA. So we will not leave them behind as NRAs and RECs in shaping AMA. They are part and parcel with them. We consult with them. And we are moving into finalizing a framework for collaboration in the ecosystem. So we are developing an AMA, AMRH, NRA collaborative framework that will define the linkages. And I think lastly, what I want to also emphasize is that understanding that experts that are going to support AMA scientific and technical work will come from the regulatory authorities and the RECs. Since the treaty came into force, we did an assessment of REC capacity. We currently have a report on the capacities that are existing in the RECs, on the gaps that we need to strengthen, and we are mobilizing support from member states and partners to support strengthening of the REC harmonization programs, because we know that unless they are strong, then they can effectively anchor. The countries, a number of them have gone through benchmarking, and they have developed institutional development plans, the WHO benchmarking, but not all of them. So what we did recently is that we did an assessment of country implementation of institutional development plans, so that based on our findings, the successes, the gaps, and where we need to strengthen for them to anchor AMA, we now are going to develop a plan. In August, we have a meeting actually of countries to look at the assessments and agree on how they can effectively contribute to AMA. So we are really just ensuring that we take a holistic approach, and we ensure that we don't leave anyone behind when it comes to all the three levels of the regulatory ecosystem in Africa.
Thank you much. Here's a good question. I think I would be doing a disservice if I don't ask, because I'm part of the Fight the Fakes board, and it's important for us to push this Fight the Fakes issues. And Cynthia has asked that you mentioned that substandard and falsified medicines and the fight against that will be handled within AMA. How are we going to balance this between AMA, the RECs, and the NRAs? I know you mentioned very accurately that the national regulatory authorities are the people with what they say, boots on the ground. I always say that whenever there's an adverse event, you don't ring the national helpline, you go to your nearest pharmacist, yeah, because that's your first point, or your neighbor. So how are you going to do that? How are we going to handle falsified substandard drugs in this?
Yeah, so we are not waiting for AMA because we know this problem is here, and we are not waiting for the DG to have his team. And as I said, we are building on the AMRH. So under the AMRH, we actually have already started taking steps on issues around SF, and we are working with the regional economic communities as well as NRAs. We know and we are aware that as a continent, and the issue of SF is a cross-border issue. The Gambia issue ended up in so many countries in the region. And similarly, we are also saying that the Cameroon issue now will also end up in the different countries in the region, or even beyond the Central Africa region. So we are doing two things currently. We actually have already started. We have started the process of developing a continental plan on SF, which we are going to do in consultations with all the key stakeholders, relevant stakeholders that are important for us to really combat substandard and falsified medicines. Because we understand that if we are to make the continent attractive to even investment in pharmaceuticals, we need to clean up. So we are coming up with a plan on how to handle SF cross-border, complementing the interventions that will be done at the country level, but also strengthening the countries where they need capacity. The second one that we are doing is that we are forming a network of country focal points on SF, which are going to be sharing information, sharing data, sharing expertise in a very efficient and effective manner, so that we are able to deal with SF as a cross-border issue. So these are the two key things that we are currently doing, and we'll make sure that as we go along, we develop a very comprehensive approach with the consultation of all the key stakeholders, ensuring that we tackle SF issues as cross-border issues and not country-specific issues only. But also we have the African Medicines Quality Forum. I'm not sure if you're aware of the African Medicines Quality Forum. It's our technical committee that deals with laboratory capacity and of the National Quality Control Laboratories. So with that, we have set up a subcommittee that is really looking at market surveillance. And it is strengthening the lab capacity to ensure that they're able to really move and push the technical aspects when it comes to laboratory functions on detecting substandard and falsified medical products, medicines, yeah.
I think you're right. It's if you go on Twitter somewhere, you also got the latest laboratory enhancement program with African Union and African CDC on antimicrobial resistance. So it's quite good. Now, I want to finish on time to show people that we don't overrun things, that we are professionals on this. The last question is, how are we going to engage with European Medicines Agency and FDA? As you know, we have to live together with them, and hopefully we can have AMA joining ICDRA conference next year. How are we going to work with these two? And short answer.
A very short answer. We already have established a relationship with the European Medicines Agency. We are working, because we know the only similar type of African Medicines Agency is the European Medicines Agency. So we have established a relationship. We continuously exchange knowledge, exchange information. The design of the AMA is really taking a lot of examples from the European Medicines Agency. So there's an ongoing relationship, and we'll make sure that we strengthen it. Last, I think 3-4 months, we were with the US FDA, so that we are also able to learn, leverage, benchmark, because as we are setting AMA, we need to benchmark on existing strong regulatory authorities across the globe. AMA will not operate in isolation, but it will have to network and partner with other regulators globally.
Thank you much, Chimwemwe Chamdimba. I think it's been an amazing insight, and I think we are very honored to have your insight and help us. In conclusion, we're thanking you profusely from all of our patients and all of our stakeholders from AMATA, also from our hearts, within our hearts. We would like to conclude this session on time to say that we are all reconvening in Botswana for the WHO Africa regional meeting. And we hope to take some of these findings forward. And we're asking everybody to join us. Let's see what we can do with this big 5 regulatory member states that will be there. And also the economic big 5 will be there as well. Let's see how we can all work together. So all of our audience who have stayed on for an hour, giving us a valuable hour in your life and time. Thank you very much. Keep following us, and we will keep you up to date what is happening. And let us all thank Chimwemwe for her time and enthusiasm for this. Thank you very much.
Thank you very much. And we'll meet in Botswana. I'll be there.
Thank you. Good.
Thank you.
We'll call it time. We're exactly on time, 11 o'clock. Please do have a good evening, afternoon, and think about what's been said and how you can help us. Let's create this agency whose fruits, as we said, and shared will be enjoyed by the future generations of Africa. And let's do some good all these years. Thank you.
Thank you very much. Bye-bye.